Good morning, everybody. Thank you for joining us in person. Thank you for your patience. Our presenter today is Dr. K.I Mbuyane. He is a compassionate and committed medical doctor whose journey in healthcare began at the University of Pretoria. He holds a BSc in Human Physiology and MBChB, completed in 2009 and then in 2015, respectively. He went on to complete his internship at Johannesburg Academic Hospital and fulfill his community service at Standerton District Hospital, where he further developed his clinical skills and love for patient care. He is currently practicing emergency medicine at Midstream Mediclinic and enjoying this challenge. In addition, he works alongside Dr. Mahomed as an assistant in Orthopedics, broadening his scope and experience within the medical field. Dr. Mbuyane's passion for emergency medicine is rooted in his deep interest in trauma management and the critical care space, where every second counts and every decision matters. Outside the hospital, Dr. Mbuyane is a devoted husband and proud father. His family is his greatest motivation and the foundation of his drive to provide the best care possible to those in need. So thank you so much. We're very lucky to have you present to us and happy to learn a bit more about you after working with you for such a long time.
Okay, thank you. Good morning, everybody. Today we're going to be talking about acute compartment syndrome of the extremities. Let's get to it. So the first thing, our main objective today will be basically to define what compartment syndrome is, and also to describe its clinical importance, and also to understand the anatomy of the muscle compartments with the pathophysiology of compartment syndrome as well, and also to review the classifications of compartment syndrome with the risk factors that can lead to a patient developing compartment syndrome, and also to recognize the clinical presentation, because it's very important, and how to diagnose it as well, and then summarize its management, treatment, complications, and prognosis. And then we're just going to talk about a few clinical parts of practice regarding compartment. Okay, so introduction. So with regards to limbs, the muscle groups are all in human limbs are divided into compartments, and then each compartment is bound by a strong fascial membrane. So with regards to compartment syndrome, what happens within that compartment, that tends to be an increase in pressure, and then that pressure is actually not good for the muscles because it compromises circulation and the tissue function. And then with compartment syndrome, it can be acute and chronic, but today we'll be focusing on the acute compartment syndrome. So as I mentioned earlier, it's the reason why we're doing this because it's very important. It's a surgical whatever emergency, and if it is left untreated, it can lead to permanent muscle and nerve damage. So the most common sites where compartment syndrome tends to happen is basically the leg and the forearm, but it can also still happen in the hands, the feet, the buttocks, and the thighs as well. Okay, so our definition of compartment syndrome, as I mentioned earlier, is basically an increase in pressure within a compartment of a muscle, and then which then tends to compromise the circulation and the tissue function of that muscle, leading to anoxia and ischemia, and then if left untreated, to necrosis. So it's because of that, it's basically a surgical emergency which needs urgent intervention. And as I mentioned earlier, the most common limb that's affected is the calf and the forearm. Which is hence, because of it being a surgical emergency, it's very important for us to recognize it early so that we can intervene immediately to basically save the limb. So with regards to if it's missed, as I mentioned earlier, acute compartment syndrome can lead to irreversible muscle and nerve damage. With regards to nerve and muscle damage, it tends to happen within the critical time period, which is basically 4 hours since the symptoms presented. Okay, so we'll focus on the anatomy and the pathophysiology just to basically get an understanding. So the picture I have there is, as I mentioned, the leg tends to be the most common site. It's the calf there. So with the calf, there's basically four compartments. You have your anterior compartment, and then you have a lateral compartment, and then with regards to your posterior compartment, you have a superficial and deep. And as you can see there, each compartment is surrounded by a fascia. So that's why an increase in pressure within a compartment tends to basically reduce the circulation, therefore affecting the function of that muscle, because within a compartment as well, you have your neurovascular, what you call bundle, which is because of the increase in pressure, that tends to be the one that's affected, leading to the using circulation and function of that muscle. So with regards to the pathophysiology, there's a lot of theories, but the one that seems to be standing is the arteriovenous pressure gradient. So what happens, there'll be an insult, like for instance, trauma to that muscle, and then the muscle will swell up, and then with that swelling up, there's basically now a decrease in inflow, but then there's an increase in venous pressure that then leads to compromised capillary perfusion, which leads to tissue ischemia. If that problem is not resolved, then it can end up leading to necrosis. So yeah, the other thing that you need, that's quite critical regarding this is because they talk about the pressures. Also focus on that and how to calculate the pressures and so forth. But then nerve damage, which can lead to be irreversible, usually happens when the delta pressure is less than 30 centimeters, 30 millimeters of mercury. So the delta pressure is basically when you get the diastolic blood pressure of the patient minus it with the compartment's pressure. I'll talk about it as well, how to measure the pressure of each compartment. And then anything less than 30, that's when it tends to be a bit of a problem for nerve injuries. So, and as I mentioned earlier before, the muscle damage tends to happen within the critical time periods, meaning 4 to 8 hours after the patient starts to present the symptoms. Okay. So this is basically a schematic of the pathophysiology. So as I mentioned earlier, you have an injury, be it trauma, be it bleeding, be it any bleeding diathesis, and then there's swelling. Because of that swelling, then there's an increase in intramuscular pressure. That increase in intramuscular pressure then leads to decreased perfusion pressure of that muscle or of the compartment, which leads to hypoxia. And then with hypoxia, pH drops and then there's cell damage. And if that's left untreated, it becomes a vicious cycle to the point where it ends up in necrosis. So that's why it's very important for us to recognize it early so we can intervene and prevent that. Sorry, guys. And prevent the vicious cycle of muscle necrosis and nerve necrosis. So, and then with regards to the classifications, so we have 3 classifications, depending compartment syndrome, established compartment syndrome, and irreversible compartment endpoints, which is where we don't want to end up with a patient. So with your impending compartment syndrome is basically when the pressure increases and then there's reduced perfusion, but then there's still no tissue damage as yet. So, and then with regards to management of that, it's very important to do basically serial clinical assessments, and then you do your compartment pressures as well. And then they also advise that you can do a prophylactic fasciotomy. Then with regards to established compartment syndrome, there's basically 2 types. There's the early stage and the late stage. The early stage is basically when it's with less than 4 hours. In that case, it's basically still reversible. So that's when they advise that we do an agent decompression, which is fasciotomy. With regards to the late stage, there's a debate there because, as I mentioned earlier, muscle injury tends to happen 4 hours after the onset of symptoms. So they say it depends on patient. It's patient specific because the treatment plan then because muscle injuries happen, the surgeon will have to assess whether they basically do a fasciotomy with the muscle debridement or they do amputation. Because there's risk factors as well of doing a fasciotomy when the muscles have already necrosed. So that's why they say it's basically patient dependent. Irreversible endpoint, that's what we actually don't want to end up with. So that means now the muscles and the nerves are basically damaged. As I mentioned, the 2 common parts is the common size of the compartment syndrome tends to be the arm and the cuff. So one of the signs of the permanent damage of the upper arm is basically of our palms contracture, which is basically a flexion deformity of the wrist and the fingers because of the permanent muscle damage. And then with regards to the foot, it's a foot drop. So with the etiology and risk factors, so you can divide it into traumatic causes, non-traumatic causes, and site-specific causes as well. So the most common one being basically long bone fractures. Long bone fractures, the most specific one being the most common one being the tibia, and then crush injury as well, because as we mentioned with the pathophysiology, the muscle gets traumatized, swelling, decreasing in tissue perfusion and so forth, and burns as well, and vascular injuries and so forth. And then with regards to non-traumatic, the most common one is your ischemic perfusion injury, and then also with and spontaneous hemorrhages as well. And then we can also group it as a site-specific, meaning the upper arm or the lower limb. Like for instance, the common thing when we put in a drip, and then the drip basically tissues. The fluid goes into the tissues, increases the volume, and increases the pressures and so forth. And then with lower limb, the most common one is they mentioned the snake bites and the DVT as well. Okay, so this is the one that I want us to focus on the most because it means any recognition, means early diagnosis, therefore early treatment, so that we prevent the complications. So contrary to what we've been taught at school, they told us about the 5 Ps. According to the latest research, they said out of the five P's that we taught, that at least the 2 ones that are specific is pain and paresthesia. Pulselessness, pallor, that's a late sign. So with compartment, the main one that we need to focus on, that for instance, as when the patient comes in and complains of pain out of proportion to the injury, and then also when you examine the patient, basically the patient has severe pain upon passive stretch, and also when you fill that compartment is test and wood lock. Those are the 3 most specific ones that we need to basically must give you a high alert. Paresthesia as well, it's considered still in the early stage, but then the ones that I want us to focus on, the main ones, the first 2 that I mentioned. And then muscle weakness, as I mentioned, muscle necrosis tends to happen after 4 hours after the onset, so it's also a bit of a late stage. And then paresthesia is a very, very late stage, so we shouldn't focus on that one. So there is basically the time frame as well, as you can see, from 0 hours to 2 hours. And then as I mean, the other point that I want to mention is the critical time window, 4 to 8 hours. That's where we don't want to end up, because it means most likely there's nerve and muscle injuries. Yeah. Okay, and then as I mentioned, then the diagnostic approach, the main one is history and clinical examination. And then if you're lucky enough, we can do the compartment pressure measurement. So there's different ways to measure it. The bottom one is basically it's a Stryker handheld manometer. So the way that one works, it's the most common one. So the way it works is basically what it does is a syringe with the gauge, and then with water, you go into your compartment, you aspirate about 0.3 mils of the saline in there, and then you zero it, then it will basically give you a number that telling you the pressure. As I mentioned, what you don't want, it's basically so 30 is the key number. You don't want a compartment pressure above 30. And you don't want your delta pressure less than 30. Those are the key numbers. So because usually the normal compartment pressure is between 0 to 8. And then if you have those 2, the clinical picture, and lucky enough you have the manometer, then you need to act promptly and involve the surgeon so that they can come and assess and most likely take the patient for a fasciotomy. So in terms of the lab findings are actually not really diagnostic. So the main thing is a clinical diagnosis. Okay, and then after you've diagnosed it, then what do you do? The first step is basically remove all compressive, what to call external compressions. If the patient has a cast, you remove the cast. If the patient has a dressing, you remove the dressing. And then it's important that you must keep the limb at the level of the heart. Don't elevate, don't drop it at the level of the heart, because you don't want to drop your perfusion pressure as well. And then as the other thing, give analgesia, give oxygen as well. And then if the patient is hypotensive, and the other thing that I actually want to mention, if patient presents with hypotension, the delta pressure actually changes. It doesn't go from 30, it goes to 20. Anything less than 20, then with hypotension, it's considered compartment syndrome. So if the patient is hypotensive, you give fluids to basically collect perfusion pressure with the limb at the level of the heart, and then you call the surgeon, and then the surgeon must basically act immediately. Okay, with surgical management, the mainstay is usually the fasciotomy. As I mentioned earlier with the anatomy, each compartment is surrounded by fascia. So what we do is basically release that fascia so that the pressure can decrease within the compartment, therefore alleviating the pressure on the nerves and the vessels as well. The critical time, as I mentioned, 4 hours. You would like to act within 4 hours, because after 4 hours, there's some element of muscle injury, which can be possible. And then say in terms of the surgical techniques, there's basically 2 techniques whereby you basically to make 2 incisions on the lateral and the medial aspects, depending on which if basically the anterior or posterior compartment or lateral compartment has ACS, or you can do a unilateral incision where you just cut on one side. And then post-operative care, it's very important to still monitor for compartment syndrome of the limb, and then also for other systemic signs like infection, because you went and cut there, wound infection, sepsis as well, and ulcers and so forth. So remember I spoke of the critical time period, which is anything between 4 to 8 hours. So there's always a debate to say, do you usually go and do a fasciotomy after 8 hours or not? But then we say it's actually not advisable, because what you do now, you know after 8 hours muscles are injured, nerves are injured. So what you're going to do, that you're going to go do a fasciotomy and increase the risk of sepsis and so forth. So the most advisable option by then is an amputation. Okay, and then with regards to the complications, what we don't want. So if ACS goes untreated, you get your muscle injury, which is permanent, and your nerve injury, which is permanent, and you can get your contractures as well. Like I mentioned, the Volksman contracture, and you can get, because of the nerve injury, you can get paralysis as well, rhabdo as well, which can ultimately lead to renal failure, infection as well, and then, as I mentioned, because 75% of the risk factors or the cause of compartment syndrome is fractures, you can get a non-union of that fracture, and then unfortunately you can also get a limb to be amputated. So with regards to the prognosis, the mortality rate for in compartment syndrome with severe trauma is about 15%. And then and that's why it's very important that we diagnose this condition very early, and then of course the delayed intervention leads to the poor limb function, and also can lead to what to call poor bed mortality for that patient. So yeah, but after fasciotomy, what needs to be done as well? Once the wound is healed, they can also start considering skin grafts as well, and just to cover that area. So, but out of this, the main thing that I would like to basically focus on is that early detection or early recognition from us clinicians is very important, so that we prevent all of this from happening. Okay, so just to end it off, the key points that I'd like to focus on, or just to emphasize, is whenever a patient has trauma or comes complaining of pain out of proportion, and also when you examine and you find that the person has pain upon proportion, that compartment is tense and tender, always have ACS. in mind, because you can intervene early, and then you can also basically help save that limb of that patient. Okay.
Thank you. That was very fast, huh? Like resuscitation. Well done. Emergency doctor.
This is how it falls. Phone calls as well. You have to listen very carefully. It's like,
Anyway, I have a just simple question for you.
Mm.
I mean, look, it's a nice, beautiful presentation. And the questions that one question is about the roles of muscle enzyme.
Oh,
Which is more sensitive? The CK globally. That's one. Two,
okay.
how do we make sure that our colleagues does not confuse compartment syndrome with necrotizing fasciitis, which
Oh.
bothered me, just like kind of having petrol, putting a light on it.
Okay, to answer the first one, the location. With necrotizing fasciitis, usually the affects, because with compartments, as I mentioned, the two common areas usually your limb and your forearms. With fasciitis, usually the perineal area. And also there will be some skin changes with trapezius around our.
The fasciitis can happen even in the limb. You can also have that one spread them,
Okay.
as long as fascia.
Okay.
It's not, we commonly see on the perineum area, but also can be in the leg.
Yeah.
But the most important, I think, the erythema problem that's that on the legs, because with patient with necrotic fasciitis, obviously, with them, you will see the signs of infection.
Exactly.
You will see the skins are red, they're very tender to touch.
Yeah.
They're really quiet. You could see actually you could follow pressure-wise that's actually increasing levels under the factor. As compared to compartment syndrome, which is really more swollen leg, but in the skin sometimes are not, the blisters become a late sign, Yeah, so I think perhaps that's where, and that's why it's very important not to confuse the two fasciitis, because the current fasciitis can be deadly.
Exactly.
Okay, so with the acute compartment syndrome, yes, you need an early intervention, but also again, sometimes a lot of interventions are done really very unnecessary early, because people sometimes end really making vasectomy and it's not indicated, because sometimes you find the patient actually bleeding to muscle compartment, and then people call it fasciitis, or they call it as an acute compartment syndrome. Yeah, so I think it's very important to do that. In terms of your testing, I mean, you mentioned very well that needle, which my leg actually went numb. How realistic is that?
So that's why that one they say is usually advisable to be done by the surgeon, because they know the landmark, know where to go and how to measure it. For us in the ED compartment, in the ED, what you call sphere, it's better we just clinically high suspicion for the surgeon, if they want to come with the with the monometer, then they can do the monometer.
And if the surgeon is Kruger National Park, what happens? Because sometimes they go hunting, not the surgeons. And then there's nobody for 2-3 hours. What happened? You go to hold on.
Well, out your scalpel.
Well, that's the one thing that I remember they always told us that when you do a fasciotomy, is that it doesn't help you just make a little cut here. When you actually have to extend into the wrist, and you need to extend into, so you need to, otherwise you lose the distal and the proximal areas. So it's actually a surgical technique that we all need to learn, because I think a fasciotomy is way more extreme than we normally comfortable with.
Online, any lively questions? You guys are giggling there. Either you guys know all the answers, so you want to really put some question out there. Any questions?
Can we go back to that page of all the causes? But I think one important thing is just that pain out of proportion. Because whenever we speak to somebody that's had a bad outcome from a cast or something, it's just, they always tell you that they've had pain out of proportion. They told the doctor and the doctor didn't listen. Gave them stronger painkillers. I get very nervous if there's a limb involved and the pain is severe. At least the one other thing, when we fly patients out, a patient that has a cast on a fresh cast, we actually bivalve the cast. Because if you think about it, you medevac, so you bivalve the cast all the way to the skin, and then you wrap it again with a great bandage. So that if you have a compartment syndrome developing, then you can just release the bandage. Just imagine you have a fiberglass cast on the patient,
Yeah.
and you're sitting there in 30,000 feet or 8,000 feet altitude, and the patient develops a compartment syndrome with a fiberglass cast in your leather. It's not going to go down well.
And there's no space inside the flight either.
Yes.
You think about bubbles and grips and things, which you don't.
I think there are a lot of lovely comments there.
I think the thing for us as well, we see it a lot, and I think it probably happens a lot more than we think is we drip tissues.
Oh, there.
No.
Yeah.
And especially in the ward, because sisters will just
Often.
and
Is that question?
you see a lot of
Yeah, they
you see a lot of times where a arm is swollen up,
Yes.
and we just call it cellulitis.
The one thing that's quite important that we don't think of is IVACs, infusion pumps. So infusion pumps, when the seniors show for the, especially for the medevacs, they showed us how to set it up. And what we don't realize is that a infusion pump is set up for an adult or a child or a baby in terms of the pressure. Now, if you take an adult infusion pump and you put it on a baby, the whole thing is about the trigger in terms when there's an obstruction, especially for instance with the tissues. So if you put an adult infusion pump on a baby, by the time it alarms when it starts to tissue, there is tremendous damage in terms of the infusion, and that can cause compartments. And then the other thing is when we send the patient for a CT scan with contrast, we don't have a proper IV, and then they push in that contrast, and everything goes into the tissues.
Yeah,
That's a high risk.
I think the worst is sometimes having extra compartments syndrome in absence of massive trauma. Sometimes, but even sometimes insect bite can actually give that, or so sometimes you need to, and sometimes we don't have the luxury of actually investigating everything. So I think high index suspicion is very, very important. And I think I always say that you can't substitute thinking. Thinking is something that you have to think. If you can't think, there's no substitution for that, unfortunately.
You asked which one is more sensitive, the CK or mine. I don't mind.
You haven't answered that.
I forgot about that question. So according to what the information I read, they mentioned CK more than micro. Yeah, they mentioned CK more.
Yeah, but I think the reason that because CK is a specific muscle enzyme as compared to microglobin. Yeah.
But also CK is much more affordable to ask.
In practical terms, it also is not quicker.
More quicker to get it, yeah. But telepacificity actually.
Good question here from a Danielle Brown, who asked, please may I ask what the medical causes of compartment syndrome are, and is it possible to have chronic development of this?
Lovely question. Yes.
Bring up that page.
That page.
Causes.
So the causes, it needs there under the non-traumatic causes.
The technical support, yeah.
Sorry guys, you got a physician running the IT, so you can imagine.
Okay, so to answer your question, Daniel, from the few ones that I know is the medical causes any hematological condition, like for instance, a person who has hemophilia, because they have a high risk of bleeding and they can bleed within a compartment, and then therefore increasing the pressure. And any patient who's on any anticoagulants as well, because they have a high risk of bleeding, they can bleed within a compartment. And then what other?
Like ruptured Becker cyst, also can give you that, And sometimes, just as I say, somebody just twisted its ankle because they got a bleeding tenderness, and then they can also bleed inside. So the list goes endlessly, But obviously, the issue that you look at, if the leg is discolorated, then you're concerned about there's a bleeding with the breakdown or him. And then, so the question, I think electrolytes, I think we've seen that rhabdomyolysis in context of low phosphate, and then also other electrolytes that could also play a key role, but those tend to be more generalized than anything else. Yeah.
And it thrombosis, increase in venous congestion.
There used to be a name for it, actually. If you have a DVT with the involvement of the artery, then you get into compartment syndrome. There's a name for it. I remember when we were doing local schools, It is a very good name for it. Darren Academic Institute. No, you guys remember, like there's a syndrome where you have a muscle debility with the inflammation adjacent artery, then you got constriction, then you get complete.
There's good old Google. Compartment syndrome as a result of venous thrombosis is uncommon, but you can get it.
Yeah, you do.
It says phlegmasia.
Yeah, but that's it's actually the PCD.
It's
You know,
phlegmasia.
PCD, yeah.
Roland.
There we go. Yes.
Venous thrombosis results in elevated compartment pressure.
Wait,
The beyond DVT.
The next
So a
yeah.
very proximal,
Yeah.
severe
So
DVT.
it involves the arterial system. I don't know.
Well, inflammation. I think there's inflammation. There's something to do with the artery. Pressing.
Yeah, it's
Because of the swelling, and then you have compression.
Yeah, it becomes bleeding slowly.
involving the whole distal limb.
And those distal bells going on.
Yeah.
I still remember one time I had it was Victoria's Hospital. I had a female patient. She was actually a medical student, and she actually had a proximal DVT, and actually went into the common iliac veins. I mean, she came in with severe pain. Now, when you examine the distal leg, you think, okay, it's a DVT.
Yeah.
But then the warning sign is like the pain is out of proportion. And then you realize, but the pain goes all the way up, and we did the.
No, we have the same in the water
Yeah.
now.
So I mean, you always have to keep that in mind, like a very proximal DVT.
Yeah. So I think that's very important. Proximal DVT is also one of the things. And I think, again, the most important thing is always not to. Don't assume, please, no assumptions. In medical and EC, assumptions are the wrong thing. You just don't assume. Be clinical and touch, feel, and make an accurate diagnosis. If you don't know, you ask your colleagues. Danny is a walking dictionary that probably can help you out quite a lot in your EC department. Yeah, we have great respect for him. Yeah. So I think we all learn by knowing, by feeling, by just don't assume, please, because assumption really lead to quite a lot of mistakes. And most of patients with the compartment syndrome will end up as medical legal if it's not done. So I think it's very important that you ask for help as soon as possible and act as soon as possible. And the difference that I think the teaching was that if you find someone who cry, most of the time in the term of the accident, someone who cry probably is more safer than someone who doesn't cry. When it comes to compartment syndrome, when they cry, I think maybe you need to attend to them. Maybe just go and check what's happening. Don't allow them to cry. It means probably the pain is really out of control. Yeah.
I think the good thing is, and we're very spoiled in the environment that we work in, is that saying of phone a friend. I mean, we've got a whole panel of specialists that is walking distance from us. Now, I know you're in a rural hospital, it's not that easy, but it's always good to have somebody on speed dial that you can call, especially at WhatsApp. You send a picture, you send a device, you say, listen, I'm worried about this patient. Can you give me an opinion? And quite often they mention something that you didn't think of, that you can investigate.
Yeah.
Guys, I guess any quick questions? We have another meeting coming at 8, so we just want to get a wrap in. Any other questions? Yeah.
Bianca Vermeulen, she's got her hand up. You can
Bianca?
speak up.
Good morning. Good morning.
God, I'm so shocked. I thought you've gone out for
We haven't seen you so long.
retirement or.
It's been quiet, but here we go. Well done, Kwazi. Thank you very much. It was very informative. The only other thing I wanted to add is I think next time, Kwazi, that fits in with this lecture very well is the morbidly obese patient with a low velocity knee dislocation, because that fits in with this compartment syndrome. It is a catastrophic injury. And once again, if you don't listen to the patient in the first half an hour to 40 minutes, when they say that this is the worst pain they've ever had, and the only thing they did was to trip over a shoe or a child's toy, those are the things that would fit in with this. But then eventually we all answered all the questions we had in any case about how you can recognize it. And the only way to recognize these injuries is through a high index of suspicion and phoning a friend. So well done, guys. Thank you very much.
Thank you, Bianca.
So just the other thing I want to mention is that, and it applies to compartment syndrome. It also applies to ET cuff pressures.
Yes.
And we focus on that in aviation as well because of your pressure changes. So we always say like the cuff pressure shouldn't be more than 30 centimeters of water, and we talk about the differential here is 30 millimeters of mercury.
Yeah, I understand. Yeah.
But if your patient is hypertensive, that all those measurements is out the door.
Yeah.
So your hypertensive patient is at so much more. So in other words, your shocked patient is at so much more risk of other complications, raised intracranial pressure, compartment syndrome, cuff pressures, all those things.
But they did mention as well with regards to hypertensive one to say if you don't consider the age.
20.
Yes.
20.
So,
Okay. Thank